Okay, you may proceed.
Okay, thank you, Nina. So for the second lecture, let me introduce first. It's an honor for us today to have Dr. Hiew Fu Liang. He's a neurologist from Sunway Medical Center. He completed his undergraduate education in International Medical University in Malaysia, and subsequently completed his postgraduate study in internal medicine in 2009, and obtained his fellowship in neurology from Ministry of Health in 2016. He was trained as a neurologist in the Ministry of Health with experience working as specialist registrar and also a research fellow in Birmingham, United Kingdom. I think without any further ado, I would like to invite Dr. Hiew. The floor is yours, Doctor. Thank you.
Thank you, Hafiza. Can you hear me?
Yes.
Okay, yeah. So just let me share my slide. Okay, I think before I start, I think there was this question to Prof. Kamaru just now with regards to how do we actually, test for inconsistency in the upper limbs in the patients that comes to you with weakness or any form of neurological disorder. As a neurologist, we have many different types of tricks, and some of the tricks may sound quite cruel, but it is something which is doable and it's actually quite useful. And just to share with you some of the tricks that you can do to kind of like, to see whether the patient is actually faking the neurology sign or whether it's actually a truly a neurological deficit. For example, if someone that comes to you with upper limb weakness, what you can do is, if the power is zero, in the upper limbs, you can just simply just lift up the hand and you just drop it onto the patient's face. But of course, you must also hold it in between just to avoid if the hand is really weak and then actually hit the patient's face. Let's say if you were to drop it and the patient's, it's a natural process for you to kind of like avoid, dropping your hand onto your face. So it is a good way to see whether the weakness is truly zero or, is actually something which is not able to lift up the hand against the gravity. And of course, these are one of the tricks that you can do to kind of like see whether the weakness is actually something genuine. On another hand, let's say you have someone that have a lot of tremors, it's just non-stop shaking of the hand. What you can do is you just do something called what we call a distraction. You ask the patient to perform a task on the contralateral hand or the legs. So when you ask the patient to do a form of, for example, if the hand is on the right side having tremor, and you ask the patient to perform a circular movement on the left side of the hand, naturally, when the patient trying to perform something, a purpose voluntary movement on the contralateral hand, the tremor will naturally just, somehow either disappear or reduce significantly. So this is also another way for you to actually test whether the patient's neurology is something genuine. And of course, there are many other tricks that you can do to kind of like elicit whether this is a true neurology or not a true neurology. But I think it comes with experience, and with time you will know that this is something doable and it's quite easy to do as you have the experience of doing it. Yeah, these are some of the tricks that you can follow. All right. Before I start, I will just have to thank the Neuro-Emergency SIG Special Interest Group of this emergency society for inviting me to speak on this topic called peripheral neuropathy, what an ED personnel should know. It is actually a big topic, I would say, and I was trying to simplify it in a way that easier for you to absorb what am I trying to say and easier for you to put into practice what I'm trying to tell. You do not need to worry about the slides, and if you want the slides, I can always email you. I will put my email at the end of the talk, and you can just email me, and then I will just email you the slides so that you can have it as well. There's no secret, and then there's nothing. There's no copyright. You can use it freely. But when I email you the slide, I will remove the patient's video because of privacy concern. Okay, I will just start my lectures now. So my lectures is practically divided into 3 sections, which is based on the major common challenges that you see as a doctors in either in an emergency department or whether you're in an outpatient setting. So the first is how to efficiently identify patients with peripheral neuropathy. So I try to put it in a way that you are in a non-neurology setting. In the neurology setting, like us as a neurologist in a major center, you have all sort of different gadgets for you to play around. You have all sort of different tests for you to do to diagnose a peripheral neuropathy. But in a non-neurology setting, is something which is very different, and it's purely based on clinical. So I'll speak about why is it difficult to identify peripheral neuropathy is because the overlap symptomatology. Some of the peripheral neuropathy presentation might come exactly the same as the muscle disorder or the neuromuscular junction disorder, as mentioned by Prof. Kamaru earlier. So these are the differential diagnoses that you would like to consider, but there are some clues that pointing toward peripheral neuropathy. So I would like to also touch on how to identify patients that require specialty consultation. Basically, as a emergency doctors or as outpatient doctors, you need to know that there are some cases of a patient that comes to you peripheral neuropathies actually in the neuromuscular emergency, such as a patient with Guillain-Barré syndrome. So these are the cases that need attention immediately, and there are cases that comes to you with very subtle peripheral neuropathies that can be seen as outpatients. So these are the cases that you might want to identify and make appropriate referrals. At the same time, if you were to follow up these kind of cases that you have referred to a neurologist, like what Prof. Kamaru did just now, the patient that initially comes to you with some form of peripheral neuropathy, but at the end of the day, you will somehow surprises come along. It's very true that somehow you will see patients with conversion disorder, and you can also see patients with initially you thought to be something like a peripheral nerve problem, but it turns out to be a muscle problem. So these are the surprises that comes along that give you a lot of satisfaction if you were to follow up the patients until the end. And the cases were illustrated by Prof. Kamaru was absolutely beautiful. Okay, and the third things that I'm going to touch on is how to treat a painful neuropathy. Patients doesn't move; they don't normally, are in agony. They don't normally complain so much. But when the neuropathy is painful, it is something that you will be able to do something at your own setting to at least help the patients to relieve the pain. Which is one of the major concerns of a patient that comes to you as an outpatient consult. So how common is peripheral neuropathy? In the general population, it probably runs about 2.4%, but as the generation gets older to above, more than 55 years old, 8% of them might come to you with peripheral neuropathy. So this is something that I would like to just give a short recap of what Prof. Kamaru has actually mentioned. Peripheral neuropathy is actually manifest or characterized by lower motor neuron lesion. It's simply a lesion that affects the nerve fibers that travels from the spinal cord to the muscles. This is why some of the mimics of muscle disorder, some of the mimics of neuromuscular junction disorder might appear exactly the same as the patients who comes to you with peripheral neuropathy. But clinically, so peripheral neuropathy normally comes with what we call a flaccid paralysis. They are flabby, they have no power. This is what the common presentation of peripheral neuropathy. Plus, a signs of sensory deficit, whether this is in a glove or stocking distributions, dermatomal distributions, that they lose the vibrations, they have no impaired joint position sense, and some of them do come with positive symptoms, which is pain, and also a temperature derangement. You see muscle atrophy if the peripheral neuropathy has been there for some time. And you see fasciculation if it is a motor predominant axonal loss form of neuropathy, such as in patient with motor neuron disease. Majority of them are either atonia or hypotonia. Majority of them are areflexia or hyporeflexia. I use the word majority is because not all patients with peripheral neuropathy has completely hyporeflexia. Not all patients with peripheral neuropathies come with complete hypotonia. They do have some tone. They might have been reduced in terms of the tone and also the reflexes, but they're not completely absent. Majority of the patients will have absent of Babinski sign, but some of them can be normal at the initial stage. As I mentioned, neuromuscular junction and the muscles pathology are the main differential diagnosis of a patient with peripheral neuropathy. So I just going to show you two videos up as I go along. If you can spot my mistake as I present my cases, you are excellent. If you can spot the mistake in between, then you are excellent. I just to show you the cases, just to see whether you actually follows, or it's actually easier to illustrate cases based on photos and also video. With this COVID thing, there's no hands-on, there's no physical meeting. So I think it's always good to just show some videos, for you to have a look. So the first case, have a look. These two cases, what do you think? Whether they are peripheral neuropathy cases, whether they are neuromuscular junction, whether they are muscle, or whether they are just conversion disorder, whether it's just malingering. So the first case, both has difficulty walking. So I'll just show you again, yeah. Just have a look. Just a quick idea of see whether you have any idea of whether these are what problem they are. Okay, I don't have the answer for you. Just let me just go through, and then you probably have an idea of what these cases are. So diagnosis of peripheral neuropathy is purely clinical, right? Clinical diagnosis, you do not need special state-of-the-art cutting-edge technology. You do not need any form of special instrument or also tools to diagnose peripheral neuropathy. So when you see a patient with peripheral neuropathy, if you suspect peripheral neuropathy, you look at the pattern of weakness first. So whether they are symmetric or whether they are asymmetric. You see the pattern of the weakness, whether they are more of proximal weakness or they are more of distal weakness. And you look at whether there's any sensory involvement, motor involvement, or both, or in some patients, they come with autonomic dysfunction as well. And also whether they are present of some extra peripheral features, for example, bulbar weakness or respiratory muscle weakness. You ask for the history of progression, which is what I call temporal evolution. It is something which is very important to determine the urgency of the peripheral neuropathy. So you look at other associated features, whether there's any upper motor neuron involvement or whether there's any family histories. But of course, if available, you can conduct some tests, for example, nerve conduction test, EMG, or even some special imaging, ultrasound, MRI, to see whether this patient has peripheral neuropathy. You do a genetic testing, you can send some antibody if you want to, or any advanced neurophysical technique. But investigation is not something that easily available. And it is most of the time not necessary to diagnose a peripheral neuropathy. It is more important when you want to establish the causes, or at the end of the day, what are the long-term, prognosis. Yes, investigation might be more relevant. But in terms of establishing the diagnosis of peripheral neuropathy, most of the time you do not need this kind of special equipment. All right, the first case that I showed you just now. She's a 25-year-old lady, previously well. She has this progressive weakness and numbness of 4 limbs for 3 weeks. And she came with paresthesia. She had difficulty in walking, as you can see from the video. She couldn't even stand on her own. She required support. She felt very imbalanced. Her bowel and the urine are normal. And when you see from this video, you can see that she has got foot drop. You can see that she had difficulty in getting up. All right. So of course, in the full neurology setting, like where I am now, you can do all sorts of investigations to tell you that, look, I have done this. I've done a constant test, I've done the imaging. Yes, you have peripheral neuropathy. But do you actually need that? You don't. So what you need is just have a look at the patients. You know that if this patient had peripheral neuropathy, based on what you can see clinically, all right, so it is something that you need to establish as a clinician. So from an outpatient setting or from an A&E setting, it is not something which is, so straightforward. Again, neuropathy, muscle disorder, or some non-organic manifestations. All right, so what do you do? The next step is you go into the details. Look at these 2 videos. She's got bilateral foot drop. She has got bilateral wrist drop. So by just looking at these two videos, you know that this patient have a peroneal nerve weakness. This patient have a radial nerve weakness. Okay, she's areflexic. She got a glove and sensory distribution sensory loss. So it's got impaired joint position sense and vibrations. And these patients has peripheral neuropathy involving the sensory and the motor system. So you know that, look, you have a patient that comes to you with predominantly foot drop and also wrist drop. So this is very clear that this patient have peripheral neuropathy because muscle problems tends to come as proximal weakness. So when they got a distal weakness like this, you know that this patient have most likely a peripheral neuropathy. So the history is just built on extreme diet supplement, with intensive weight loss over 3 months, from 66 kilos to about 46 kilos. So this patient have a nutritional related neuropathies. If you were to test her B1, B6, B12, and also to test the folate acid, they are all at the lowest border. Diagnosis is straightforward. In fact, when you see a patient with wrist drop and the foot drop like this, and you get the history that patient have a rapid weight loss, you know that they are nutritional deficiency. These are the patients, you put them on supplement, they will resolve and they will resolve completely. Right. Second case, a 65-year-old lady, diabetes for 18 years, came to you with numbness of the feet and also, a neuropathic pain. Okay, there was no weakness, as you can see from this video. She walks perfect, but you can see that, she's lifting up her hand, meaning that she has got slight imbalance. Because diabetic patient tends to lose their joint position and they tends to walk slightly imbalanced, their footing on the floor. And this is what we call pure sensory neuropathy because they have no weakness. All right. So when you were to do some form of nerve conduction test, you see that there are some degree of neuropathy, but the neuropathy is not severe to impair so much in terms of their function. But having said that, majority of the patients that comes to you with diabetes, and when they have got nerve problems, in fact, they actually have got a nerve problem much earlier, where most of them remain asymptomatic. However, remains asymptomatic doesn't mean that they have no neuropathies. They still have a risk of getting an ulcer in the feet. They have a risk of still getting diabetic foot ulcer. So this is something that you need to pay attention because majority of the patients with diabetes only until a certain level of severity don't need to come to you. At the very early stage, they don't. Okay. So the treatment is optimized diabetes controls, diabetic foot care, and to treat the neuropathic pain if there is any. Right. Of course, some of them come to you with a very clear-cut diagnosis. For example, if you see a diabetic dermopathy, you see a wasting of the skin on the feet, you can see the wasting of the small muscle in the feet, and also you can see this hyperpigmentation kind of lesion. You know that this patient has, most likely, you probably don't even need to, you probably can guess, by looking at the skin, you know that this patient most likely have got a neuropathy. So, to screen for neuropathies, you do not need special tools. You just need to examine the muscle power using your MRC score, okay, that we normally use from 0 to 5. And you just need a tendon hammer to check the deep tendon reflexes. You need if you have a tuning fork with you, a 128 tuning fork to check for the vibrations, and suggest some pinprick if you can to check for the sensory. And also a light touch. If you've got a monofilament, that will be the best. But if you don't, just a small cotton will do. So basically, in general, okay, if you see someone with predominantly proximal muscle weakness involving the lower limb, especially, or even in the upper limb, they are more of muscle or the neuromuscular junction problems. If you see patients that reduce or have a hyporeflex reflexes or reduce or absent of sensory, you know that this patient is most likely a nerve problem. This is one way of doing it. Proximal muscle weakness, they are more of muscle problem. Distal muscle weakness, they are more of nerve problems. Nerve problems, they do comes together with deficit in terms of the reflexes and also the sensory. This is one way of knowing whether this is nerve or muscles problems. Another way of very very quick way of knowing whether this patient have a nerve or muscle problem is to ask them to walk. If the patient can walk on a heel, meaning that you can lift up your, your feet and you walk on a heel, the nerve most likely will be normal. If the patient can walk on tiptoe, most likely the muscles are normal. So this is what this is a very quick way of knowing whether differentiating whether this patient has got a nerve or a muscle problems. Okay, once you have diagnosed peripheral neuropathy, once you know that this is the patient with peripheral neuropathy, you need to determine the urgency. Urgency of peripheral neuropathy means that how soon this patient should be seen by a neurologist or being referred to a specialist care. So there are features that determines, urgency. If you see a case that comes to you with peripheral neuropathy, acute, subacute in onset, or rapidly progressing, or in a severe form of neuropathy where they impact functionally very badly. So these are the cases that need to be seen early. So you have a length-independent peripheral neuropathy, meaning that in a diabetes, in general, we call it, for example, you got diabetes, you have a length-dependent peripheral neuropathy, meaning that the longest the nerve are being affected first, compared to the shorter nerve. So your nerve in the legs are longer compared to your nerve in the hand. So in a diabetes, we call it length-dependent because your peroneal nerve, your tibial nerve, your sural nerve are longer than the nerve in your hand, which is your median, ulnar, and also your radial. So your leg will be affected first, compared later on only your hand. So this is called length-dependent neuropathy. Length-dependent neuropathy normally, if the history is long, they are normally non-urgent. But you have someone that have the length-independent, meaning that this patient has got, for example, upper limb, the shorter nerve affected more compared to the longer nerve. It is something that requires a special consultation. Multifocal, meaning that asymmetric, hand one nerve, leg one nerve affected. We call it, in the past, we call it mononeuritis multiplex, or multiple mononeuropathies. So these are the cases that require special consultation. If the patient that comes to you with motor predominant neuropathies, and also patient that comes to you with other form of features, for example, severe dysautonomia. So these are the cases that actually require special attention. All right, as an ED personnel, this is probably one of the most important slides that you need to know is, if you have someone that comes to you with a peripheral nerve disorder, you always look for whether there's a respiratory involvement, bulbar involvement, or also autonomic functions involvement, because these are the features that will determine whether the patient needs an emergency care. So peripheral neuropathies can present as a neuromuscular emergency. So what we call a neuromuscular emergency is because they have this impairment of respiratory function, bulbar function, and also the autonomic function. Respiratory function result in respiratory failure, and patient become tachypneic, develop CO2. And this has been covered by Prof. Kamaro just now. And patients develop respiratory failure, the use of excessive muscle to breathe. They develop paradoxical breathing. And some of them may even require emergency airway rescue, where they probably need intubations and things like that. And they require ICU care. Yeah. So if a patient that so-called impending, going to develop respiratory weakness. So how do you identify this kind of patients clinically? Patients probably looks pretty well, but they are not in respiratory failure. Your cases are very good. Your SpO2 is still 100%, but you want to predict whether this group of patients is going to go into respiratory failure. You always look at the neck, your neck flexion and the neck extension power, and also whether they got pharyngeal muscle involvement. So if your neck flexion and the neck extension is weak, you know that your diaphragm is going to be weak, because your neck flexion is your cervical's power. So when your cervical is weak, means that your C3, 4, 5 will be weak as well. You know that the diaphragm is going to be weak. So these are the patients that will, are potentially going into respiratory muscle failure. And those with pharyngeal muscle involvement, meaning that they cannot clear the secretion, they have dysphagia, they're going to have salival pooling, and these are the group of patients that might go into a very fast deterioration in terms of the respiratory function. Also, you look at whether they have autonomic dysfunction, where they have hemodynamics fluctuation, your blood pressure is up and down, develop tachycardia and bradycardia, and these are the patients that is very difficult to manage. And majority of the patients who die from peripheral nerve disorder is due to autonomic dysfunction. Of course, in an outpatient setting, autonomic dysfunction can present as something which is chronic. For example, stomach just feel like indigestions. They have erectile dysfunctions, orthostatic hypotension, and also sweat abnormalities. In fact, erectile dysfunction is one of the very common presentation among patients with diabetic peripheral neuropathy. It's something that you want to know and you want to ask them personally, because something that as an Asian, we don't normally, so open telling the doctors that, I have these problems, but these are the problems that is showing early sign of autonomic dysfunction where they can present as erectile dysfunction. Okay, peripheral nerve doesn't just come as the peripheral nerve. There comes with a series of symptoms. They have got, some of them, they have medical problems associated with the peripheral nerve. So this is what we call symptomatology. This is something that you would like to elicit from the history. A very quick one. For example, this is the second case that I show you in the very beginning, correct? The videos. So 25 years old lady, she presented with fever, myalgia, arthralgia, a week following an influenza vaccine. So she subsequently developed progressive muscle weakness of the lower and upper limbs and a facial muscle weakness as well. She had difficulty in breathing on admissions and also have swallowing difficulty. You know that this patient have a, neuromuscular emergency because the respiratory and the bulbar muscle weakness is actually affected. As you can see her on examinations, she got a proximal muscle of 3 or 5, distal muscle of 4 or 5. With the deep tendon reflexes, which is reduced, and the sensory examination is normal. So you're unable to ambulate, as you can see from the video, is very weak without assistance. Typical lumbar puncture actually shows abdominal cytological dissociations. So she got this antecedent event where someone developed infection, and followed by that, they developed symmetrical ascending paralysis, which the symptom from the onset peaked within 4 weeks. So it fulfilled the criteria of someone that has Guillain-Barré syndrome. So after that, normally Guillain-Barré syndrome will recover over the next few months, right? So again, diagnosis of Guillain-Barré syndrome is purely clinical. Diagnosis is purely clinical. When you look at the patient comes to you with progressive weakness in both legs and arm, and they are areflexic or reduced tendon reflexes. These are the cases that can be due to a Guillain-Barré syndrome. Of course, there are other supportive criteria where normally as a Guillain-Barré syndrome, they normally will progress within the first 4 weeks, and they will reach a plateau, which is the most severe form of manifestation within 4 weeks time, and subsequently they will start to recover. So this is a typical presentation of Guillain-Barré syndrome. If there's someone that comes to you have a progressive symptoms, continued deterioration of 8 weeks, 1 month, 2 months, or even more than that, you know that this is more study and not a Guillain-Barré syndrome, because naturally they will peak, at about 4 weeks, and subsequent Guillain-Barré syndrome typically present with. They have relatively symmetrical presentations. They don't really have much sensory symptoms, from the onset, and some of them have cranial nerve involvement, autonomic dysfunction, and if in a proper setting, you need to do a lumbar puncture to look at whether there's actually a base protein, but there's no cell in the CSF. And typically, you do a nerve conduction test, you determine whether this is a demyelinating or this is an axonal form of Guillain-Barré syndrome. So again, you do not need that in outpatient, in the A&E setting. Clinical is just what you need, right? So we know that patients know that. How do you predict, again, this patient is going to develop respiratory failure, apart from what I have mentioned just now? Look at the neck flexion extension, whether they have SpO2, whether their gases are okay. So you know that this patient might or might not develop respiratory failure. But only 3 questions that you ask yourself, you can know that whether this patient have a higher risk of developing respiratory insufficiency in Guillain-Barré syndrome is how many days between the onset of weakness and hospital admissions. So the earlier they come to the hospital, If they have facial and bulbar involvement, yes, they are more severe form of Guillain-Barré syndrome. And when it comes to you with a very weak score, meaning a really weak power, you know that this is a severe form of Guillain-Barré syndrome. If you were to score these three features into a score like this, you can predict what the percentage of them will eventually develop respiratory insufficiency based on the score. If you have somebody that comes to you with a score of 6, you know that this patient, 78 to 80% of them is going to develop respiratory insufficiency within 1 week of onset, 1 week of admission. So you know that these are the patients that you would like to pay more attention, get them into the ICU and treat them properly. Right. Management of Guillain-Barré syndrome is mainly intensive care. You know, you start them on IVIG or given the plasma exchange, which is the proven treatment for Guillain-Barré syndrome. Although the mortality is not high, 3 to about 7%, but by right, no one should die because of Guillain-Barré syndromes. Because this condition is treatable, and we know that as long as you can support them for 3 weeks, 4 weeks until they reach the plateau, and subsequently with 4 to 6 weeks. Right. So Guillain-Barré syndrome is something that is acute, rapidly progressive, and they have severe functional limitation with autonomic dysfunction. So these are cases that require urgency, and these are the cases that require special attention. Okay. Next case, 21 years old man, stateless, language barrier, can't even figure out what is he talking about. So he came to you with this kind of progressive bilateral lower limb and upper limb weakness and numbness. You can see from here, very weak, couldn't move. All right, 4 to 6 week weakness and numbness. So is this GBS or this is not GBS? Yeah, I mean, I'm asking, but I got to answer myself anyway. So normally, if the patients that come to you peripheral neuropathies, they comes to you with Guillain-Barré syndrome, it's a very short history. You're talking about, couple of weeks kind of presentation that comes to you. Normally, they do not develop severe wasting. If someone that comes to you with, this kind of history, but the patient develops severe wasting, became emaciated like this, you know that this is unlikely to be a Guillain-Barré syndrome because you do not develop such a significant wasting of muscle weakness due to that. So you know that this is something wrong. Although the history might sound like Guillain-Barré syndrome, but they are not. All right. So these are the refugees that travels along from other parts of Southeast Asia coming to our countries. And because on the way, they develop severe starvation, there's lack of food, there's basically no nutrition at all. So they develop severe malnutrition and they become very emaciated. And these are the patients who eventually develop very severe form of peripheral neuropathy due to a vitamin deficiency. So thiamine is one of the critical nutrition that is required for metabolism of carbohydrate and also amino acid that require for the function of the central nervous system. And these are the patients that will eventually lose all the thiamine because they are being starved from food, and your thiamine will deplete within 2 weeks. Your entire body thiamine will deplete within 2 weeks if you have no constant supplement of thiamine from your food. And because of that, it results in this kind of presentation where they lose the weight, they develop severe weakness. So as I show you from my previous videos, even someone that go into a strict diet, with a very significant weight loss, you develop this kind of presentations where you develop severe wrist drop and also the foot drop. So patients with taking a lot of alcohol, pregnancy, severe hyperemesis gravidarum, they have different GI bariatric surgery, or even those in the critical ill patient in the ICU, they do have such presentations. Supplement them with a proper vitamins is crucial to prevent this kind of presentation. So of course, they can come with 2 different forms of neurocardiogenic syndrome. We call it beriberi. So the wet beriberi is peripheral neuropathy with high output heart failure. They develop edema, profusion, they develop, difficulty in breathing, and some of them might even require ventilation support. The dry beriberi is purely on the peripheral nerve, as what I showed you just now. And the patients might also have an autonomic dysfunction. Weight loss, emaciation is the distinguishing features between this kind of presentation with Guillain-Barré syndrome. Of course, This patient also have, wet beriberi, where they also have high output cardiac failure, where you do not see in a patient with Guillain-Barré syndrome. You can see that the elevated JVP. You can see that there's pitting edema in the lower limbs, and you can see that, they got facial weakness. It's pretty resemble patients with cranial nerve involvement in Guillain-Barré syndrome, but they are not, all right? And they have even nystagmus. Yeah, they develop central involvement in terms of this kind of lack of vitamins. So these are the features that you would like to have a look at. Resemble even some form of what we call that central features of patients with Guillain-Barré syndrome. They do look alike, but they just due to other form of etiology. So presentation that favor a thiamine deficiency compared to Guillain-Barré syndrome is if the symptoms present greater than 3-week symptoms, and they develop confusion, nystagmus, vocal cord dysfunction. They have a normal CSF or lumbar puncture, elevated lactate, or when you do an NCS, there are some pattern of pseudo-sparing, which is absent. So these are the features that are pro-thiamine deficient. All right, treatment is, diagnosis is pretty easy. Send a serum thiamine level, which is, can be sent to the private lab, and you just replace them with the thiamine, and they should be fine. Okay. Right, I'm going to, next case. We have spoke about symmetrical ascending paralysis. Now we go on to something different. 60 years old lady, hypothyroidism for 4 years on carbimazole. So she came with a left foot drop. Look at how she walks. But actual presentation is bilateral lower limb weakness. You know that her left foot is actually just on the other side, and you can see that clearly the left foot is not as strong compared to the right. This is her hand. She has weakness of both hand and fingers, and she has numbness. And you can see that her thenar muscle is wasted on both sides, and you can see that she has got bilateral claw hand, and all the intrinsic muscle of the hand are affected. Distal muscle involvement, muscle atrophy, claw hands, foot drop. This is peripheral neuropathy. This is something in contrast to a muscle presentation where they are more proximal manifestation. So basically, she got a late onset neuropathy. She got progressive asymmetric. So that is the clue, asymmetric. Onset of sensory motor symptoms. Basically, left foot drop. Also, she got bilateral claw hand. So in the past, we call this mononeuritis multiplex, but now we call it multiple mononeuropathies. So you dig into the history, as I tell you, symptomatology. They have not only peripheral nerve involvement, they have probably other form of involvement as well. She has got a bronchial asthma that was diagnosed, a few years back, but she has got no history of childhood asthma at all. So currently she's on a steroid inhaler. When you do a simple full blood count, you can see heavily eosinophilia in this kind of cases. We probably with reactive thrombocytosis. So this patient actually have what we call vasculitis neuropathy, where the diagnosis is basically hypereosinophilic syndrome. So eosinophilic granulomatosis with polyangiitis. I mean, in a more glamour way, we call it Charles-Ross syndrome. I mean, neurologists tend to use glamour words, but it should mean the same thing. These are the patients that have got vasculitis. And Charles-Ross is actually a rare systemic necrotizing vasculitis that affects the small to medium-sized vessels. And some of them, and normally they are associated with asthma because of hydroeosinophilia, and also blood tissues hydroeosinophilia, where you can just draw from the full blood count. Treatment is by steroids, oral penicillins, and subsequently put on immunosuppressant. Okay. Next case. And also the left hand over several months. You can see it starts with hand first. So this is what we call a non-length dependent problems. Feet, because the longest the nerve mark, so they are the dependent, length dependent. But when you see non-length dependent problems, you know that hands are being affected more. So she got the hands or no, and also you can see from here, you can see some, a burn mark on the hand. So the finger is flexed, and you got a very prominent claw hand as well. So when you see this kind of patient, you know that look, they have peripheral neuropathies. So in the more advanced setting, you can always do a nerve conduction test, and in this case, it shows what we call demyelinating neuropathies. But when you do a lumbar puncture, they are normal. It's negative for any infections, and you screen them for any form of infection investigation. There's no evidence of connective tissue disease, vasculitis. There's no evidence of Poyam syndrome, malignancy, paraneoplastic, nothing. So these patients were eventually being diagnosed as a CIDP, chronic inflammatory demyelinating polyneuropathies, and was started with IVIG and also methylprednisolone. He actually improved initially, but subsequently, so this is what happened. He developed this kind of rash, in the body, after given steroids, and we can see that the ear loops are taken. You can see this kind of hyperpigmented rash, body and the whole body. So with that, Dr. smear, and you can see that there's multiple bacilli, leprosy bacilli in the skin. That suggests that this patient actually has got a leprosy. Again, non-length dependent. Something is not really a normal pattern of patient that comes to peripheral neuropathies. Always have to think of something. Yeah, so he's not actually a CIDP. He's actually a leprosy that resulting in a peripheral neuropathies. So the treatment is to treat the leprosy. Okay, next case. This is something which is very commonly seen in an A&E setting. But very often they are being misdiagnosed, and are very often not semi-diagnosed because sometimes the diagnosis of a doctor, right? The diagnosis that we make as a doctor is very much dependent on what the patient tell you. If the patient can't describe to you properly the symptoms, sometimes we make wrong judgment, including myself. I'm not perfect. So sometimes when the patient tell you very vague symptoms, right, you just being strayed away from the diagnosis, and then you just go all the way, don't know where did you go. So these are the cases that comes to you very often in A&E. But eventually they're being referred to see many other doctors, and eventually they'll still come back to the neuro. So 54 years old lady, she has got no non-medical illness. She came to the outpatient because of left shoulder arm pain for 3 weeks. But majority of the patient, when they tell you pain like this, right? No, we thought that it's probably because of joint, muscle, or things like that. But if the patient can tell you specifically burning, sore, tingling, and the key features is numbness. If the patient have pain at the same time and the patient feel numb, so it is very likely that this is probably more to a nerve problem than a joint, muscle, or anything else, because the numbness or the tingling or the paresthesia itself is very much neuropathic. So if you can elicit the history, you won't miss the diagnosis. And the pain is very severe until the patient cannot sleep. And most importantly is when you give them NSAID, PCM, or other painkiller, it just doesn't work unless if you give them neuropathic pain treatment. So this is very much a nerve problem. So clinically, they have deltoid, and also the bicep muscle weakness, but you don't see so much of wasting because the symptom is normally very recent. And I've seen quite a number of cases like this, following, our recent vaccination program. I'm not saying because of vaccine. I mean, just saying that, somehow just coincident. And they have this reduced sensation. When you do a pinprick test and you see a reduced sensation over the one side of the affected side, you know that this is probably more of a nerve problem. And these are the patients that comes with brachial neuritis. And even, of course, in my setting, I can just do an MRI and confirm the diagnosis and start on treatment. But you need to have a strong clinical suspicion of a patient that have got this kind of neuritis. Then you make a proper referral. And majority of them have very severe pain. They can't sleep. So you give them treatment like gabapentin or Lyrica, so that it can help them. If their symptom very much reduced to gabapentin or Lyrica, you know that, look, this is most likely a inflammation of the nerve, brachial neuritis, right? So treatment required steroids, neuropathic pain control, and you need to refer them for physiotherapy and also occupational therapies. Majority of them so severe the pain, some even go into depression, because the pain is just so severe. And then most of the time they have seen many doctors, and painkillers just don't solve their problems. Again, multifocal, one side asymmetric, need special attentions to the specialist. In contrast, if someone comes to you with a unilateral shoulder and also hand muscle atrophy and also weakness, in fact, in this kind of patient has got no sensory symptom, they have got no pain. Sensory modalities are all normal. You can see from here, the left shoulders are very much wasted, and the bicep, the tricep, including the supraspinatus and the infraspinatus muscle are all very wasted. So these are the cases that comes to you with motor neuropathy involving one side. You see fasciculation. Always think of progression of more than 8 years. You know that this is unlikely a motor neuron disease. Yeah. So it is some form of anterior horn cell that affecting the motor nerve more on one side. So think of monomeric amyotrophy. These are something chronic that having this kind of progressive symptoms. This kind of case is not something which is really that urgent because the history is 8 years and the patient has got no severe pain. These are, I'm not saying that these are not important cases, but they will still need to see a neurologist, but it is not as urgent as compared to the brachial plexus, brachial neuritis patients earlier. Okay, if you see a fasciculation like this patient earlier, and you see a motor involvement with no sensory involvement, always look into the tongue and to see whether the tongue also has got fasciculations, atrophic tongue, because you always do not want to miss patients with a motor neuron disease. So other than the tongue, you also look at the arm, the upper limb, lower limb, and the cranial nerve to see whether there's any fasciculations, muscle atrophy. Because some of the patients are actually amyotrophic atherosclerosis disease that they kind of like progresses relatively fast, and then the prognosis is actually not so great. Yeah, anterior horn cell disease can also present as an infective cause, for example, polio, West Nile virus. But we hardly see polio nowadays because of the vaccination, very successful vaccination program of a polio virus. And West Nile is not something which is common in Malaysia. It's probably more of North America's kind of conditions. But normally the symptoms come with prodromes, symptoms like fever, malaise, nausea, vomiting, abdominal cramps, diarrhea. But the neurology symptoms will come after that. And some of them have, severe presentation they even require respiratory support because they develop respiratory failure. But this is hardly something that we see nowadays because, improvement in terms of healthcare vaccinations program. West Nile virus, something that is very, very uncommon in this country. But if you were to look into the literature in Malaysia, you do see that some of the orang asli do have a West Nile virus positive serology. But the majority of them are asymptomatic. They just have the virus serology, meaning that they are just being exposed to it in the past among all the orang asli, but they don't manifest the symptom per se. So, but however, being in this part of the world, when you know that some of the group of people still having this kind of serology positive, you know that the virus are still around. But of course, majority of them are actually quite mild and they don't come to you with acute presentation. Okay. Rabies, yeah. So this is something that we don't commonly see in West Malaysia, but it is very common, not to say very common, this commonly symptoms of, commonly a diagnosis among doctors that seeing patients with asymmetrical neuropathy in Sarawak. Paralytic rabies is something that you have to always be aware, especially if the patient comes to you with a GBS kind of presentation. Somehow it is a virus which is very interesting. The bite of the dog and the inoculation of the virus can be on one leg, one limb, but the presentation can somehow symmetric involving both limbs, right? So it might appear as ascending paralysis that pretty similar to a patient that come with GBS, where eventually you will have a respiratory involvement, you have got a central nervous system involvement, but the differentiating features is virus in the rabies cause encephalitis, and they are, inevitably fatal unless treatments are given at a very early stage. But for those in the rabies prone area, for example, in Sarawak, these are something that you always want to consider if the patients come to you with this kind of extending paralytic presentations. Something that you might want to ask the history in detail, simply because some of the patients might have a rabies bite, dog bite, probably 5 years or 10 years before that, where the manifestation is very much delayed. It is not something that, you know, it has to be like recent dog bite. No, it can be something which is, you know, long history back many years ago, right? So again, motor predominant cases need specialties consultation. All right. So the third part of my talk is management. Not all peripheral neuropathy can be treated, but of course, the main aim of the neuropathy is to treat the underlying etiology and to treat the underlying cause and to reverse the neuropathy. But unfortunately, not all the neuropathies can be treated, or not all of them will recover completely. Some of the patients might still have a neurology injury to the peripheral nerve, and because of that, they develop pain. And this is where a symptomatic treatment is actually very important. Patients that come to you with neuropathic pain in outpatient or the A&E settings typically complain of burning, pins and needles, electrical kind of shock, or even a shooting pain. And some of them have allodynia, where the pain itself can be stimulated by even a non-painful stimuli. For example, just a light touch but cause pain. Or hyperalgesia is like, you know, something that is painful but to a normal person, but it's very much painful to the patient with kind of nerve problems. Sometimes the neuropathic pain itself has become so chronic that, you know, it causes mental problem to the patient. They develop depression, anxiety, and sleep disturbance because of this kind of neuropathic pain, which is typically worse at night. So solving the pain problem, or not to say completely solved, but at least helping with the pain is something that we can do. And, you know, knowing that, you know, not all the nerve can be, you know, treated completely, but at least giving them symptomatic treatment is something which is very important. So you got the option of giving them gabapentin or pregabalin, which is anticonvulsant drugs. And I find it amitriptyline or nortriptyline, which is a triglyceric antidepressant, helps in many cases. Yeah, so it is something that you can try, but all these medication can also cause a little bit of drowsiness, but you need to pre-warn the patient in terms of drowsiness. You know, tell them that, look, when you first started on this kind of treatment, you probably have to not stop driving for, you know, a couple of days when you get used to the treatments. And if the patients have got severe pain, develop depression, you know, SSRI, for example, duloxetine is a good option. And majority of the patients, when you want to put them on treatment, you know, so some of the patients do feel that, you know, you also need to give something that can potentially help with the nerve recovery. You can give them alpha lipoic acid, ALA, which is available in most of the pharmacies as a supplement. And capsaicin cream, which is the chili cream, which is very good for topical applications of a patient with neuropathic pain, is something which I find it quite useful. And it's quite difficult to find it on a outpatient pharmacy setting, but I think online you can get it with quite a reasonable price. But of course, opiate and tramadol are good for painkillers, but opiates tends to cause constipations, and tramadol sometimes can be a bit drowsy. But these are the options that you can give as treatments for patients with neuropathic pain. As you can see from here, I did not put B1, B6, B12 or neurobionts or, you know, as supplement. Okay, it's simply because some of the cases that has this kind of deficiency need to be diagnosed properly. So sometimes I don't tend to start them first until I have sent off the investigations before I actually put them on this kind of supplement. It is good because once you put on this kind of supplement, your subsequently testing of your B1, B12 levels and all these things will not be accurate anymore. So, you know, because of the interference from the supplement itself, so I don't really put them so early. I do put them later on, but not so early until I have done all the investigations. Yeah, so the take-home message is, again, back to the three major challenges, the three major sections of my talk. Identify patient with peripheral neuropathy. It is a clinical diagnosis. You do not need any special form of equipment to diagnose peripheral neuropathies. The symptomatology of a peripheral neuropathy might overlap with other neuromuscular disorder, for example, myasthenia gravis or muscle disorder. So always get the history properly and now look at the presentation of the patient and determine whether they are peripheral neuropathy cases. Second, identify those that require specialties consultation. Those that comes to you with recent onset acute or subacute peripheral neuropathies. Patients that come to you with rapidly progressing peripheral neuropathies. Patients that come to you with non-length dependent peripheral neuropathies. Patients that comes to you with associated features, for example, autonomic features. Patient that comes to you with bulbar or respiratory involvement, need urgent attention. Patients that come to you with pure motor neuropathies, yes. Asymmetrical neuropathy, yes. So these are the cases that you would like to refer. So treating painful neuropathy is something which is important because we want to manage the pain and know the expectation of the patients. And also it's just to help them because pain itself can be very, very severe. And because of that, they might even develop depressions. So most cases will require specialties review. Most peripheral neuropathy will require specialty review because we eventually need to determine whether they are treatable or they are non-treatable. Okay, with that, thank you. If you need the slide, I can always email you. This is my emails. Yeah. So I just want to ask, anyone has spotted by mistake? Just let me look at this one. Yeah, excellent, Nasrina. You are right. So this is the patient that is not GBS. So the patient is not a GBS patient because, as you can see, she doesn't really have this typical what we call it. Just let me stop my share first. How to do this? As you can see from this case, yeah, as you can see from here, her proximal muscle is affected more than the distal. Okay. Some of the patient with a muscle weakness that also tends to get, reduced tendon reflex because your muscle is weak. And some of the these patients do actually have got a sensitivity which is normal. All right. So these are the cases that they might look the same as the patients with, Guillain-Barré syndrome or peripheral nerve cases, but they are not. So these are the muscle cases. This patient actually got neuromuscular junction disorder. All right. Excellent. Thank you. Any questions?
Okay. I open the floor. Any question to Dr. Hiew Fu Liang?
Thank you, Dr. Hiew, for such a very interesting talk. I would like to ask, in terms of how you classify acute, subacute, and chronic presentation, is there any suggested timeline that we can use?
Yeah, sorry. Acute, normally we talk about acute is something less than 6 weeks. Yeah, something within 6 weeks, you call it acute. Anything 6 to 8 or 6 to 10 weeks, you call it subacute. Anything more than that, we call it chronic. But some people even straight away, they don't really think that there's something called subacute. They just say that less than 6 weeks is acute, more than that is chronic. It depends on what field and what kind of teaching that you are coming from. But normally acute means 4 to 6 weeks normally. Yeah. Anything more than that, you can always classify them as subacute or even chronic. Yeah, but I know that some people even classify 6 weeks as chronic. So but it's something which is very subjective. Yeah.
Thank you. Second question would be, have you, since we are in the pandemic of COVID-19, have you actually encountered any patients that come in with GBS secondary to COVID-19 infection so far? I know in influenza we do see a few, but how about in COVID?
Yes, we do, but they're very mild though. I have 2 patients so far. But the thing is, you can't really prove that it's because of COVID, you see. No, it's just somehow they had COVID and then it comes to you with Guillain-Barré syndrome. But they're very mild. They do not require, they do not have respiratory or even bulbar involvement. They just have, very mild weakness, and they're non-complicated, typical form of Guillain-Barré syndrome. Yeah, and in fact, I have got one patient that I had this kind of symptom following COVID vaccine as well. Just one patient. I still remember this patient because she came to me in the clinic complaining of numbness, just very mild numbness. When you see so many patients with this kind of numbness and this kind of presentations, sometimes you tend to overlook. I'm going to admit to you that I probably have overlooked at her. So she just came to me with this kind of numbness thing of the hand. I thought just some from hyperventilation syndrome. But eventually she turned out to be a GBS. Then when I did a nerve conduction test for her, it turned out to be a demyelinating disease. But she's very mild. She's just walking around, with the numbness. And yeah, so this is the GBS that you do see. Some patients, they just come to you and complaining of numbness following the vaccine. And they're actually GBS, but they're just very mild.
Thank you, Dr. Hiew. May I know these patients are in active COVID or post-COVID? I just recovered from COVID, by the way. We call them, normally GBS we call it post-infective, GBS. After 4 to 6 weeks of infection, you get this kind of GBS presentation. This is previously, before the COVID, we call them post-infective kind of Guillain-Barré syndrome presentation. But nowadays with COVID, we call them para-infection. So meaning that they can present even during the period when they have COVID, or just shortly after that. So it's no longer post-infection. It's still during the infection of the COVID. So we call it para-infections. Yeah.
Dr. Hiew, have you encountered any GBS post COVID vaccine? Because just now you shared a case of GBS after influenza vaccine.
Yeah.
But do you have encounter after the COVID vaccine?
Yes. I have one patient.
One patient.
I mean, I have only one that came to me that I told you the one that I overlooked as a hyperventilation syndrome. She came to me with this numbness of the hand after the vaccine. I thought she was just nervous, after vaccine. At one point everybody was talking about the side effect of the vaccine, you develop thrombosis in the brain because of the vaccine. And this patient came to me with this kind of concern. She's scared she had got something thrombosis in the hand, in the head after the vaccine, and then she had got this numbness of the hand. I thought she was just hyperventilation, and then after that, when I did the nerve conduction test, it was actually a full-blown demyelinating neuropathy due to GBS. And you tend to overlook, but somehow when you concentrate so much on that cerebral venous thrombosis, you actually forget that these kind of patients, the numbness presentation is actually a form of peripheral neuropathy. But she was very well, reflexes all quite preserved. It's just the numbness. But when you do a nerve conduction test, it's just full-blown demyelination.
This patient started on the IVIG, and is it considered part of the adverse reaction of the influenza, adverse reaction of the COVID vaccine?
Yes, this patient was eventually started on treatment. Yeah, but because I got to this patient eventually started on IVIG, and but she was treated by another neurologist because she was not happy with me telling her that, look, your GBS is very mild and you do not need treatment. Yeah, and because she wanted the treatment, so I said, because based on treatment initiation guideline for GBS, if the patients do not have a significant disability, and if the patients can walk, well, and there's no severe functional deficit, you do not need treatment. I told her the same. You have numbness, I just treat you as your numbness now. but she wasn't happy with me, so she went to another neurologist and got treatment from there. Yeah, so to answer your question, whether again,
whether you consider part of the adverse reaction of
yes,
the
correct.
vaccine.
So you notify?
Notify. Okay.
Yeah.
Betul.
Mm.
Any more questions from the floor? I think there's no more question. On behalf of everyone today, I would like to thank you, Dr. Hiew, for your amazing lectures and for taking your time to speak to us today. Hopefully, we will have another collaboration with you in the future, Dr. Hiew.
Thank you, sure.
Okay. I think
Thanks for
that's
inviting
it.
me to speak. Yeah.
Okay.
Excellent, Lassina. Excellent.
Thank you. Please
Thank
don't
you.
exit yet. I would like to stop the recording first.